Good morning, everyone. We're delighted to be here to present to you about what the NMC has been doing. We've entitled our talk, The NMC Agile Regulation in COVID-19 Times. My name is Jacqui Williams and I'm one of the Senior Midwifery Advisors for Education at the NMC, and I also have my colleague here, Verena.
Hello everybody, my name's Verena Wallace. I'm another one of the Senior Midwifery Advisors at the NMC covering the policy angle.
So what led to the changes in what we've been doing was the Coronavirus Act of 2020. And what occurred as a result is that we had to amend our orders, which meant we had to amend what we could do during this emergency period. We had to work very closely with the government and our key stakeholders, and we put in measures which were ultimately to support nurses, midwives and nursing associates, as well as all those students during this emergency period. And one of the key things that we also did to support the workforce is that we were able to develop a temporary register. And what that meant is, as well as students being able to go into practice during this time, we were also able to bring people back into practice, albeit for a temporary period. The temporary register meant that some conditions did apply, so they weren't fully on the register, and they have had to work under the direction of an NMC registered nurse or midwife or other registered healthcare professional who's not on the temporary register. But they've been absolutely pivotal in supporting the workforce during this emergency period. We also put in place a lot of other measures which were there to support people already on our register or were working towards going on our register. And one of the things you will have noted is that we have adapted a more flexible approach in relation to revalidation and retention. And what that's meant is that people who had needed to revalidate during this time were given some flexible extension on that, recognising that that would have been quite a difficult piece of work maybe to work through. The other thing that occurred was that fitness to practice and registration appeal hearings, some were suspended and some needed to go online. And I'm sure you will have seen the news that those fitness to practice hearings will be restarting this month. So things are beginning to return to some new normal. Now, importantly, we needed to think about our students, which were a key resource during this time for midwifery practice. And in response, we were able to develop some emergency programme standards which enabled the approved educational institutions where these students are studying the flexibility to enable students to be in practice for the full final 6 months of their programme. And indeed, some of them have been also remunerated for that. The key principles, of course, were that they because they are still there, they would continue to be student midwives. They would also continue to be supervised, whether that be directly or indirectly. And they needed to continue to meet their competencies and develop their midwifery skills using their practice assessment document. So they were not necessarily supernumerary at all times, but they had to have protected learning time, and this was to enable them to complete the theoretical component, because our ultimate aim was that they should register as a midwife on time. And for those student midwives in the audience, I particularly want to thank you for those who opted into the extended placement. We absolutely wanted you to continue on your programme, and we hope that you will be nearing the end of your programme now and hoping to register on time as a midwife. And we recognise that you've made such an important contribution to maternity services, so thank you. However, we also recognise that some of you weren't able to opt in, and we fully understand and support that decision. It was absolutely right for you and your personal circumstances, and I'm sure very shortly, if you haven't done already, you'll be returning to practice and becoming the midwives of the future, and you'll be supported to do that. So from the end of September, we are moving into what we call the recovery programme standards. So coming out of that sort of emergency period, while still being absolutely mindful that there's some uncertainty during the autumn and December, and we will have to watch very carefully whether we need to make any further adjustments to what we enable our registrants to do and our students. But we have got some emergency standards, and these will be ensuring that placement allocations are very mindful of public health and guidance to ensure that the health and well-being of our students are adhered to. No longer will we have two schemes of supervision. We had moved into some organisations, trusts and health boards adopting our new supervision standards and assessment, and no longer adhering to the SLAPE standards. But during this emergency period, all students have moved on to that, and that will continue. So we hope that will be helpful for practice settings, that they are beginning to be much more familiar with the new supervision and assessment standards, and they will continue to support students in that way. We have also made a recommendation that where perhaps traditionally universities would have had all theoretical teaching face-to-face, we have also now said that that can be replaced with blended learning where it's appropriate, and that's to recognise the challenges for getting some students back into the university setting. And it obviously needs to be still mindful of gaining the right number of theoretical hours and learning outcomes for their programme. And the other thing that we have withdrawn during the emergency period, and we will not actually revert back, is that students in the past have had to have a 12-week period in their next academic year to meet any outstanding outcomes, whether that be through exceptional circumstances, illness or whatever. And that is no longer a standard that we set, and the universities will look at students' progression themselves rather than an additional layer of requirement from ourselves. And I know these slides will be circulated, and I've put the link there, so for those of you who want to read these recovery standards in more detail, they are there. As you can imagine, although the COVID emergency has occupied quite a lot of our time and energies, and that's been very important to do so, Verena and I are also involved in a lot of other work that we wanted to share with you, which is very pertinent to midwifery within the NMC. So we've continued, albeit in a different way, to support the adoption of the new future midwife standards, which were approved by our council last autumn and then came into effect early in the year. We've continued to do a range of activities, and we're delighted to be at the conference today. And we've also developed a new information hub that should be useful, with a variety of resources for people supporting and assessing students. And we're also continuing to do some online events, and to a lesser extent, but beginning to build up some face-to-face events. And we're very much there to support the adoption of the new standards. There has been a slight delay although many universities will still be going through their approvals over the next 18 months. Some will be slightly later, perhaps as late as 2022. So this is why it's important for Verena and I to continue with this work. I'm sure you're all aware that the NMC has a new strategy which was launched in April. That will be the 5-year strategy. And we have also begun some work on the development of a midwifery action plan which reflects this strategy. And what that will mean when this document is published is it will be very clear to see the work of midwifery within the NMC and how it is being addressed at every level, and to provide reassurance that midwifery matters are being dealt with very seriously within the organisation. Last month we also developed and had published some new preceptorship principles which we hope will be particularly helpful for students who will be joining our register shortly. And do watch out for the code campaign. During the COVID emergency, we had a lot of queries which were largely ethical in nature, and but we felt that perhaps it needed to be considered in a more dynamic way. So the code campaign is looking at some specific issues, aligning them to code and being presented in animation form. So do look out for those, because we do hope those are going to be really useful for your practice. We've continued to work on the post-registration standards, a lot of engagement, particularly online, attracting many hundreds of people within the audience, and there will be a future public consultation. So for those of you who particularly are a health visitor perhaps, as well as a midwife, that would be of interest, as well as others who perhaps have got joint registration. The midwifery test of competence has been updated for the new standards, but has been slightly delayed. So although our test centres are now open again for midwives from overseas or midwives wanting to return to practice in order for them to do the OSCE, that will still be based on the 2009 standards. But next year, the test will evolve to reflect the new standards. We also continue to prepare for Brexit. There's a lot of work going on behind the scenes whilst we're still not quite certain about the government's direction, but we're making sure we're prepared to be responsive when we have that information. And we continue to communicate with the midwifery family in a range of newsletters, including one for students, educators and midwives. And I do hope that you found those of interest, and do contact us if you'd like to contribute or like us to look at particular topics. So I'll pause there and over to Verena.
Thanks very much, Jacqui. And I'm relying on Jacqui to keep moving the slides forward during my section, because we're doing a joint piece of work on this presentation. But I'm going to just briefly take you through a little bit about the NMC strategy, which again was co-produced, views from thousands of members of the public and professionals on our register going into developing this NMC strategy, and also folk working within the NMC itself. So it's a 5-year strategy, and the purpose is about promoting and upholding the highest professional standards in nursing and midwifery, protecting the public and inspiring confidence. And then this leads us into realising our vision, which is safe, effective and kind nursing and midwifery practice, improving everybody's health and well-being. And this was an enormous piece of work, and we listened and heard and built on the evidence and the research that we commissioned, as well as getting all the views. And if you want to read the document, you'll see on the slides that the link is there. So that piece of work was published recently, and the key point about it is that what we're aiming to do is to have our values underpinning everything that we do going forward. And these values are shaping and will shape how we act and think. And I would hope that you'll see this coming through in all our connections and interactions with you. So the principles are that we're fair, we're kind, collaborative and ambitious. And the idea behind fairness is that we treat everybody fairly. It's at the heart of our role as a trusted, transparent regulator and employer. We want to act with kindness and in a way that values people, their insights, their situations and their experiences. And we've already alluded to the co-production that we've done, and this is an illustration of the collaboration. We value our relationships both within and outside the NMC and recognise that we're at our best when we work with other people. And we want to maintain our ambition. We want to take pride in our work. We're open to new ways of working. And I think, to be honest, that the one thing that COVID has done, it's pushed us all into suddenly becoming a lot more expert on ways of communicating via the internet and IT, suddenly having to be part of the skill set for those of us that maybe weren't quite as good at it as we should have been. So it's been an interesting way of learning, but it's about being open to new ways of working, always aiming to do our best for the professionals on our register, the public we serve, and each other. So it's an all-encompassing approach. And what we've also been doing is having a new approach to fitness to practice, because we're well aware of the negative connotations around fitness to practice. So what we've been doing is, over the last couple of years, is working really hard to move this forward in a positive way. So we're thinking about better, safer care, a just culture of openness and honesty, and thinking about prioritising local action, accounting for context, which I'll talk a little bit more about, enabling remediation and best use of the hearings, and also working with other people. So there's a lot to it, but I think this is well described in this illustration. And the aim of it is to have a much more positive, proactive approach to fitness to practice on the rare occasions that it's needed. And there's always the reminder that fitness to practice procedures actually affect less than 1% of the people that are on our register. So if we move on to the messages from the various inquiries and reports which have obviously fed into our work across the organisation, it's very clear that blame culture causes fear. It makes people less likely to speak up, makes people more likely to hide things if things go wrong, and that itself puts people at risk. And the risks around safe care go unchallenged if people don't feel safe to speak up. So all of those sort of messages have come into our work and thinking about the context in which people work and the policy principles that we're now looking at, which are about the context and about being people-centred, are really that we take account of the context in which the nurse, midwife or nursing associate was practicing when deciding whether there's a risk to patient safety that requires us to take any action from a regulatory point of view, and that we're taking a person-centred approach to fitness to practice, helping us to properly understand what happened, to make sure the concerns raised by patients, women or the families are properly listened to and addressed, and explain what action we can take and why. So it's much more about looking at the whole picture, the context, and, as we said, being person-centred. And this is, as I would say, it's a work in progress. We will be listening and continuing to improve as time goes on. But there are three sort of key principles that are informing this work. as well as what I've already said. And this is the recognition that when things go wrong, usually everybody contributed. Most people are usually safe and competent. They're coming to work to do a good job. And a safe and competent professional can have a bad day with tragic consequences. So again, this is the underpinning behind our new approach to fitness to practice. So what we're doing is trying to look at concerns in a different way. Is there evidence of a serious concern that requires us to take regular action? If so, why did it happen, and do we think it could happen again? And what action do we need to take if so? So that hopefully will be a much more positive approach, and it takes us into 8 context commitments, sort of putting everything together. What we've ended up with is 8 context commitments. So we're coming at it from the principle that most people refer to as are normally safe. We build an accurate picture of their practice history. We'll always act on evidence of discrimination, victimization, bullying or harassment. Where risks are caused by system and process failures, we'll concentrate on what we need to do to resolve the underlying issues. So we'll recognise cases where a nurse, midwife or nursing associate was required to use their professional judgment, and we'll respond proportionately. We'll look for evidence of remediation. So that's where something has been done and the professionals worked with their employer, worked themselves to address any gap in knowledge, and they've done this by training or considering personal context factors and so on, and they're addressing any gaps in knowledge. We'll always look into whether there was an issue around group norms or culture that influenced an individual's behaviour before we take action, and where an incident has occurred because of cultural problems, we'll concentrate on taking action to minimise the risk of the same thing happening again. So,
okay, thank you very much, Verena. So we thought it would be useful to just give you a case scenario to try and bring those commitments to life and what this might mean for a midwife who had been referred to the NMC. So this is Sarah, and she was a midwife working for a large NHS trust, but she has recently been dismissed following the death of a baby shortly after birth. And the trust had concluded that Sarah had failed to monitor the antenatal cardiotocograph and didn't follow their escalation policy and didn't keep clear and accurate records. And the trust's root cause analysis concluded that her action contributed to the baby's death, as the mother had been placed at significant risk by her. So Sarah was actually asked to provide some information about what was happening on that day, on that shift. And she said that she recognised the warning signs of this mother, and she did recognise that this woman did need a caesarean section. But she also said that there should have been 2 midwives on shift on that day, but one had phoned in sick and a replacement couldn't be found. So that meant that she was there alone. And at one point on the unit, she had a total of 3 women. She had to take 2 phone calls, which needed her action in quick succession. And so she needed to ask for help from the labour ward. And a colleague arrived and she gave her a verbal handover and then that midwife cared for the woman for about 45 minutes while Sarah was assessing another woman. When she came back to take care of the woman from the colleague, she immediately recognised that there was a problem, and she escalated the findings to the obstetric registrar. Now, what Sarah also said is that she expected her colleague to do a full assessment of the woman. And she also said, because she'd recognised the emergency situation, she hadn't been able to complete her records of time, and she needed to do them retrospectively before the end of the shift. However, she did reflect that perhaps she didn't appreciate the developing complication based on what the woman told her. And in retrospect, she probably should have continued with her care and allocated another woman to the colleague. She also recognised that she should have monitored the cardiotocograph more closely. And Sarah also shared that she had previously been under supervised practice for cardiotocograph interpretation, but there hadn't been an issue since. And she also recognised that she got distracted by the care of the second woman. But in spite of all of this, she felt that she still wanted to give up midwifery and leave the register. So when you're looking at the commitments, the starting point was number one, which is that people normally are referred to as safe. And these commitments concluded that Sarah was normally safe, but there was other factors that played a part in what went wrong. Number two, which was talking about the accurate picture of the midwife and their practicing history, they recognised that Sarah had been very frank with the NMC as to what had happened. And although there had been some historical concerns, which she shared, she'd had actually a positive practice history for 6 years since then. Number four, and you can see that when you look back and with the slides, there are 8 commitments, but not all commitments exactly align. Number 4 is looking at what was happening within the system and processes and whether there's other underlying issues. And certainly they felt that system failures may have contributed to the situation. Number 5, looking about professional judgment and responding, there were staff shortages, which was not unusual in the unit, and Sarah shared this. And Sarah, they felt this had no doubt to impact on the care that Sarah was giving. And another aspect of 5 was that it was recognised that Sarah had been put in a very difficult position. She was attempting to care for both women, and it was important then to explore her decision processes, which she had already reflected on. Number 6, we will look at evidence of remediation where a serious concern was caused by a gap in knowledge or training or personal context. And in this instance, we would consider gaining a clinical opinion so that we can assess whether Sarah's actions were so inappropriate that no competent practitioner could have made the decision she made. And of course, as I'm sure all of you are already probably thinking, there was also a colleague involved at that time, and we need to think about whether there's any additional referral that would be required. So that's an example of how the commitments that we are looking for context have been directly applied to a case history. But importantly, Sarah's evidence was equally considered, as well as trust records and clinical records. So we would like to thank you for listening, and we welcome your questions and comments for the rest of the session.
Thank you.